Hello, everyone, and welcome to McGill Cares, a webcast series supporting family and informal caregivers of people living with dementia. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret, full professor of medicine and part of the Division of Geriatric Medicine, and Dr. Serge Gauthier, professor emeritus in the departments of neurology and psychiatry. McGill Cares is supported by the Amelia Saputo Community Outreach for Dementia Care. The McGill Dementia Education Program offers a comprehensive range of free multilingual resources to educate and support people who are living with dementia, their families and caregivers, healthcare students, and medical professionals. We invite you to visit our website, mcgill.ca/dementia, where you can access educational guides, online courses, activity videos, and virtual support groups, and much more. So today we're going to be discussing new treatments for Alzheimer's disease, and we are going to be having this important conversation with Dr. Simon Ducharme, neuropsychiatrist and a clinician-scientist at the Douglas Mental Health University Institute and the Neuro. He has specialized in frontotemporal dementia and the interface between psychiatric disorders and dementia. He conducts research on novel dementia biomarkers and clinical trials, including gene therapies in frontotemporal dementia. Dr. Ducharme holds a Senior Clinician Scientist Award from the Fonds de Recherche de Québec and is the author of over 180 scientific articles and 8 book chapters. He is also the director of the McGill Division of Geriatric Psychiatry and Neuropsychiatry and the Associate Chair of Research for the Department of Psychiatry at McGill. He is also a Fellow of the American Neuropsychiatric Association. So during today's webinar, Dr. Ducharme will provide information on a new medication, lecanemab, which has been shown to modestly slow cognitive decline in patients with early-stage Alzheimer's disease, explaining how it works, who might be eligible, and what the risks and side effects are. Welcome to McGill Cares, Dr. Ducharme.
Thank you for the invitation, Claire.
So before we begin, perhaps you can just make your disclosures.
Yes. So today we're going to be talking about new treatments. So I would like to mention, as discussed in the presentation, I do a lot of clinical trials. So these are done with research contracts from various pharmaceutical companies. And I have provided advisory to Eisai, which is the manufacturer of lecanemab, and Eli Lilly, the manufacturer of donanemab, which might be another treatment in the future.
So let's talk about the big picture to begin. And so for people that are new to this topic, can you briefly explain what Alzheimer's disease is and how it affects the brain over time?
Yes. So Alzheimer's disease is a biological disease of the brain, which is composed of 2 major changes, something we call amyloid plaques, something we call tau tangles. So these are abnormal accumulation in the brains that are toxic for nerve cells and that are associated with the symptoms of Alzheimer's disease, most commonly short-term memory loss, but also language problems, space perception problem, executive dysfunction, leading to a gradual loss of autonomy, the stage we call Alzheimer's disease dementia.
So why has the approval of lecanemab generated so much attention and hope?
Well, in Alzheimer's disease, we do not, up until recently, did not have any treatment that could slow down the progression of the disease. What we were working with for Alzheimer's were either prevention measures, like trying to reduce the risk factors of Alzheimer's disease. And we have some medication, the family we call the cholinesterase inhibitors, names that could be familiar to people, drugs like Aricept or rivastigmine. These medications stimulate something called acetylcholine, which helps a little bit to improve memory and other cognitive function, but do not fundamentally change the course of Alzheimer's disease. Whereas the new class of drug that is now emerging, including lecanemab, they remove the amyloid and they change the progression of the disease. They slow down progression to loss of autonomy. So that's a major change in the way we approach Alzheimer's disease.
So could you explain what is amyloid?
Yeah, so amyloid is it's a protein that is found in the brain that has some normal function. And so usually in the brain, the protein is produced, is used, and then is eliminated. In Alzheimer's disease, for various reasons, the amyloid protein, instead of being eliminated, starts accumulating in aggregates that grow over time and become what we call the amyloid plaques. And this amyloid in this excessive quantity is toxic. So it's like a toxin in the brain. It creates some dysfunction in the nerve cell, and eventually the nerve cells die, which we call atrophy, so which is loss of brain tissue. And when you have these dysfunctional brain cells and death of brain cells, that's when you start to have the symptoms like memory loss.
So and so what causes this amyloid? Is it like certain lifestyle factors? Like
So the first factor is age. So as we advance in age, we tend to accumulate more amyloid. When people reach their 90s or 100, almost everyone will have some degree of amyloid plaques. But there are some people who start having those plaques much younger. There are some genetic risk factors for that. Things like the ApoE gene or some rare genetic variants. There are also some lifestyle factors which seem to facilitate the appearance of amyloid. Everything that damage the blood vessels in the brain, like high blood pressure, diabetes, smoking, poor sleep over time is also associated with the accumulation of amyloid. So it's this combination of personal genetic makeup, lifestyle factor leading to the accumulation of amyloid. The amyloid in itself is not sufficient to cause the symptoms of Alzheimer's disease. So amyloid tends to appear very early, but it can take many years before we start to see symptoms from that.
okay. And so what does the lecanemab actually do? Like, because right now you were mentioning the other drugs like Aricept, which slows down. So what does it actually do? Like, is it a cure? Like,
So, so lecanemab is it's an antibody, so it's a biological drug that goes into the brain and targets some receptors on these amyloid plaques and will break them down, leading to their removal. So if you look at what we call an amyloid PET scan, so that's a nuclear medicine imaging test that can essentially illuminate the amyloid plaques. Before and after lecanemab, you will see a massive reduction in amyloid. So it removes both the small forms of amyloid that we call the soluble oligomers and also the plaques. So it really targets a very core biological component of Alzheimer's disease. It removes most of it, which leads to slow down in the progression of the disease. So that will be an important concept for today's conversation. It slows down the disease progression, but there is still progression. So it does not stop Alzheimer's disease. It does not reverse Alzheimer's disease. But the goal is to keep people in the very mild stages of Alzheimer's disease for as long as we can.
okay, so that was my next question. So, at what stage are people, like, at what stage is it intended for? So, when you mention in the mild stages, so that means a person who's being diagnosed, I guess, in the very early stages are the ones who are eligible?
That's correct. So these biological drugs are really beneficial in people who are in the very early stages of the disease. So what we describe as mild cognitive impairment. So a mild cognitive impairment is there is some decline in cognitive capacity. So there is clear forgetfulness, word searching, but it is still mild, so the person remains essentially independent. So a person could be living on their own. They could be driving their car. They could be doing their groceries. So maybe they need compensation strategies, more lists, little reminders, but they are globally independent. So that's what we call a mild cognitive impairment. So biologically, we can prove there's the disease. We see there's amyloid on their PET scan, lumbar puncture, blood test. When we do memory tests like MMSE, MoCA, we do see that there is a decline, but they remain independent. That's the mild cognitive impairment stage. So these are the ideal candidates for lecanemab. Lecanemab can also be given when there are the first steps of loss of autonomy. So what we call the mild stage of dementia, which would be someone who maybe now needs help for complex tasks like managing finances, organizing errands, but people who are still independent for many other things. They could be left alone for a period. They manage all their own personal hygiene. So that's the population we're targeting, from mild cognitive impairment to very early stages of loss of autonomy.
So, dementia is the umbrella term, and there's different illnesses that cause dementia, such as Alzheimer's disease.
Yes.
What happens if a person has Lewy body dementia or vascular dementia or frontotemporal dementia? Are they eligible for this drug?
They would not. So it is a very targeted biological treatment for amyloid, and amyloid is present in Alzheimer's disease. So when we evaluate people for this drug, one of the things we do is to make sure that we have the right biological diagnosis. So we would be excluding anyone with very significant vascular component to their dementia, other type of degenerative illnesses like frontotemporal dementia, Lewy body. This drug targets Alzheimer's disease, and patients who will be selected for this therapy must have only Alzheimer's disease, or it has to be the very dominant factor.
And it sounds like with the introduction of these new drugs, there has to be probably a lot more public awareness about the early signs of dementia, right? Because people think it's all about memory loss, but it could start with a change in personality, behavior. And sometimes people, probably by the time they arrive in your office, they're already quite advanced. So how will people, like, what do you think needs to be done in terms of better educating people about?
Yeah. Indeed, knowing the other signs, also language changes. So starting to stumble on words, mix words can be a symptom. There will be a shift. So there used to be a lot of nihilism about Alzheimer's and dementia, where people would see there's a problem, but their reaction was kind of, what's the point? This is going to be progressive. There's nothing to be done. Now the situation is changing. So we are hoping to see people at an earlier stage of the disease, particularly at the mild cognitive impairment stage, where it's clear there's something happening, but the person is still independent, because that is the stage we want to preserve. The goal is not to extend disease in people who are very advanced and have very poor quality of life. The goal is to intervene when people do have symptoms, but they still have an excellent quality of life.
So take us through now the whole evaluation process. How do you know that a patient will be eligible? What tests are done? And I'm assuming that you might have to rule out some other pre-existing health conditions.
Yeah. So the first step does not change versus what we used to be doing, which is a good medical evaluation to determine the diagnosis. So we're going to be looking at risk factors, other medical conditions that could contribute, medications that could have cognitive side effects, reversible causes like low B12. We're still going to be doing our medical evaluation with a clear history, obtaining information from family, physical exam, cognitive testing. So the first step is the same evaluation. If at the end of that, we think that someone most likely has early stages of Alzheimer's disease and that they could be eligible for lecanemab, then there is a workup we have to do to make sure the person could receive lecanemab. What we need, first of all, we do an MMSE test. So the MMSE test is regularly done in practice. That's also known as the Folstein test.
Or
One
the
of
MOCA, correct?
So not the MOCA in this. So MOCA is another cognitive test.
Okay.
But for the eligibility to lecanemab, we want to ensure that the MMSE is 22 or above. So for people in family, it's a test on 30. 26 and under is considered some impairment. So ideally, the person should not be below 22. So that is a reflection of the fact that we know that the drug works in people who are early stages. Therefore, if their MMSE is too low, that's a sign that they're probably too advanced. Now, there could be some exceptions. Sometimes a patient with a lot of language difficulty might have a very low score on the MMSE and still be very independent. So there could be some exceptions. But in general, we're looking for people with scores of 22 and above, which replicates what was done in the clinical studies. So to get the medication in clinical studies, your MMSE had to be 22 and above. Then we need a biological proof that it is Alzheimer's disease, which we did not always do in the past. But now, in order to give lecanemab, you need the biological proof because clinically, our evaluations are good. We have our intuitions, but sometimes we're wrong. So in this case, we don't want to give a drug that targets amyloid if there's no amyloid. The three ways we prove biologically the disease is either to something we call an amyloid PET scan. So that's a scanner in nuclear medicine with a tracer that binds to the plaques, through a lumbar puncture. So there are some biochemistry we can measure in the lumbar puncture that show us if there's amyloid plaques or not. And then the good news is that over the last year, we now have access to a blood test called p-tau217, which is about 90% as good as the PET scan. So in most cases, it can be sufficient. So if you have clearly high value on this blood test, which is obviously much simpler than the lumbar puncture or the amyloid scan, and the clinical profile is concordant, that is sufficient. And there are a couple more things. We need to do a brain MRI. We will probably discuss that more, but there are some side effects that can show on brain imaging that are significant. Therefore, before we give the treatment, we do a specific type of brain MRI that looks for small bleeds. So most people are not aware of that, but in Alzheimer's disease, there is a subset of patients who will have fragile blood vessels and have small bleeds, small swelling that they might not be aware of. And these are people who are at higher risk of adverse event if they get the medication. So we do the MRI to make sure they do not have these small bleeds and that they're a lower risk candidate. And there's a final test to be done, which is a gene test called ApoE. So ApoE is the strongest genetic risk factor in the standard form of Alzheimer's disease. And there's a variant called ApoE4 that increases the risk. The reason why we need to do this is that in patients who are what we call double E4, which means that there are two genes are the E4 copy that increases the risk, which is maybe 15% of patients with Alzheimer's disease in clinic, especially in the younger ones. These are patients who are also at much higher risk of side effects with the drug. So if we look at the Canadian indication, they should be excluded. So there's a workup to confirm you have Alzheimer's disease. There's a workup to be sure that it's safe to give you these new drugs before we get you on them. So as people can figure out, it is a more complex process than what we used to do. But fortunately, all these tests are doable and they're now being more integrated into regular practice.
So, what pre-existing health conditions would also make it so that a person would be eligible? So, let's say I have Alzheimer's disease, but I may have a heart issue or diabetes, or I'm on blood thinners. Like, what is there anything else that would rule me out as not being eligible?
So the major contraindication is blood thinners. So other than the very low dose aspirin, which is just prevention, but anything that is a real anticoagulant, Coumadin, Plavix, Eliquis, these drugs would all make you ineligible to lecanemab. So if you are on one of these drugs, you will not be receiving it because of the higher risk of bleeding. Although studies did not really show that it made a big difference, but because logically, if a drug has the side effect of bleeding, you wouldn't want to give it to people with a medication that makes them more prone to bleeding. Other medical conditions have to be reasonably stable. So you can receive the drug if you have stable hypertension, heart disease, diabetes, hypothyroidism. None of that would be considered a contraindication. But we would not be initiating this treatment in someone where there's a very active, uncontrolled medical condition that will require additional treatment. So, for example, we would not be giving lecanemab to someone that has a cancer still ongoing, chemo, radiotherapy. We would wait until all of that is under control. Also, globally, this medication is it's not a simple treatment. We'll talk about how it's given, but it's infusions, intravenous, frequently MRIs, checkups. So it requires organization, energy, willingness to receive that. So it might not be the best choice for someone who is elderly and frail or has many other medical conditions. So there's a judgment that has to be done at a certain point because it will be very demanding for the person receiving the treatment.
Okay, so that was my next question. So now I'm eligible. So take me through the treatment process. So what is involved for me as the patient as well as my family members?
Yes. So we do the evaluation. We consider you have mild cognitive impairment. We're confident that it's Alzheimer's disease. You have no contraindication. We explain to you what pros and cons. You say, I want this treatment. So we will be registering you in the access program from the company, which will then make the connection between you and infusion centers. So the treatments are given in a network of infusion centers. There are many across the provinces. In the case of lecanemab, it's most often something called Bayshore clinics. So the nice thing about that is that they tend to be distributed throughout major cities. So it's relatively close to patients. So they do not need to come to the hospital to get that. The treatment is given as an intravenous infusion every 2 weeks. So that means that every 2 weeks you go to the clinic, get a needle inserted in your arm, and then you get the infusion, which is given. I'm not exactly sure of the time, but it's about an hour or two of infusion. So you have to stay there. And then repeat that every 2 weeks. For a period that will be determined based on evolution. But in studies in general, the minimum is a year and a half, and a lot of patients go up to 4 years and more. So
4 years and more. So this is every 2 weeks.
Yes.
Up to 4 years. Okay.
So that's why I was saying that it's a commitment. On top of that, you need 5 MRIs in the first year. So brain scans, because we want to make sure you do not have one of the adverse brain swelling or bleeding event. And so they're particularly at the beginning because that's when the risk is highest. So in the first 6 months, you will be going both to the clinic to get to the infusion and through the imaging facility to get brain MRIs very frequently.
And what about risks to the infusion site? Because I'm imagining you have to enter through the same.
Yeah, so I mean, as always with needles, theoretically there could be a risk of infection or bleeding, but that's the same for as for any other blood test you would do. It's very minimal. The drug is a biological agent, so there can be an immune reaction to it. So what we call infusion-related reaction, which we can see in, forget the exact number, but maybe about 15-20% of patients. In the overwhelming majority of these cases, they're fairly mild symptoms. They're like fever-like symptoms, chills, tremor, dizziness type of thing. These are easily manageable with drugs people are familiar with, like Benadryl or Advil, which we can give pre-infusion. They're not standard, but if someone has a reaction like this, then before the next one, we would give them those medications. The infusion clinics are all equipped with capacity to do rapid medical interventions.
Okay. So, but many people watching now have a family doctor. Some don't even have a family doctor. In order to go through the whole evaluation process, do they need to see a specialist like yourself? Can a family doctor be the one to make this referral to the infusion clinic? Like, how do they get this evaluation?
So I would say that in the medium term, this is only a treatment that will be given in specialty clinics. It is complex in terms of diagnostics. It's very complex also for the follow-up because everything is timed in a very strict way. So you cannot get, for example, your third infusion before you've had your follow-up MRI, which has to be done in a window of 2 weeks from post-infusion, get the MRI, get the report, have the doctor review it to make sure there's no contraindication to infusion number 3. So it requires complex organization that currently is being put in place in a few specialty clinics. So this will not, in the foreseeable future, be a treatment given by family doctors. We do need the help of family doctors to identify patients, start the workup, refer to specialty clinics. But in terms of treatment administration, it will be in one of the few specialized memory clinics for the moment.
Okay, so now we'll go into more of the political, I guess, details about it all. So Health Canada has recently approved lecanemab, but Quebec has made the decision to not publicly pay for lecanemab at this time. So let's first talk about what is the cost of this drug and what does it mean for those people in Quebec, for example, who RAMQ is not going to pay for it. So take us through that.
Yes. So we can start with the costs. The costs vary from one person to another because the dosing is based on weight. And so the amount of medication that you receive for costly medication, if you receive 50% more or less than the other, it will make a big difference. The price will also vary based on which pharmacy is distributing the medication. So what happens when we prescribe it? The person will be directed to centralized pharmacy or their local pharmacy to get information about a specific price. We do not have very detailed information sometimes as doctors, but to give a ballpark to people, we're talking around $30,000 per year.
Per year.
Which can vary a bit down, a bit up, but that is the cost of the medication. So obviously, it's a very expensive drug. Now, there are drugs that are as and more expensive in other domains, oncology, rheumatology. So this is not something that has never been seen before. Biologic drugs, when they come out, tend to be expensive. But that's the cost. And as we mentioned a bit earlier, we really want treatment for maybe at least 2 years. So you have to repeat that. This is the cost of the medication, which comes with the services of infusion. The rest of the costs are the diagnostic tests, like the biomarkers and the MRIs to follow for safety. Because it is a medical prescription, these ones tend to go into the public coverage, unless someone elects to do them at a private clinic.
Mhm. Because I'm imagining, if knowing our healthcare system, if you have to wait to have an appointment for an MRI, it may take months, right? And because of the every 2 weeks of the infusion, you need to have an MRI as soon as possible. So I'm assuming that people would have to probably invest more in having it privately done to have it quicker.
So that depends where people are being followed. There's some differences in access to brain imaging. The good news is that the protocol we need to do for safety screen is shorter than many other MRI. It's shorter, let's say, that if you do a brain MRI to see if you had like a stroke or cancer. So for the radiology department, they can use these shorter protocols, which takes less time in the machine, so easier to schedule. But it is a heavy burden on our colleagues from the radiology departments. So going private can be appealing. However, it is very important that the MRI follow a specific protocol and are read by someone who was trained in detecting what we call ARIAs, which are the adverse event from the medication. So it would not be advisable to go into any random private clinic and just say, give me an MRI. It has to be a partner clinic that has the required expertise, which obviously will be developed over time in many centers. But for now, example, at our site, we work with our colleagues at the La Salle Hospital, which have been motivated to learn how to do this and accommodate us for a certain number of patients. And so we have the guarantee that the MRI protocol is well done and read in the proper way.
So, talking about Quebec now, because most of our viewers are from Quebec, what is the situation here? Have these injection sites opened? How could people go about it? And perhaps why did Quebec decide to not publicly pay for lecanemab at this time?
So we are now officially running. So we have a few people that have started receiving the treatment in January. The first cases were in January, so it just started. So it is operational. It is feasible to receive the treatments. The infusion clinics are ready to have patients. The patient support program is in place, so this can be done. The government of Quebec, through the body called INES, which is in charge of evaluating the relevance and the cost efficiency of medication, has recommended against coverage from the medication. The reason why they have done that is because they mostly looked at the main studies called the phase 3 studies, which lasted 18 months. So in these 18-month studies, the drug shows that it slows down progression by a factor of about 30%. Most patients and families, when you show them the curve, the 18 months, 30% difference, they view that as quite meaningful. Now, they might wish for more, as we would wish for more, but the 30% slowing does resonate with most patients. However, Alzheimer's is not a disease that evolves particularly fast. It just gradually declines over time. So over 18 months, the difference that you get in absolute difference, so you slow down 30% less fast, but given that the slope of the curve of decline is not extremely steep, at 18 months, when you look at the absolute difference, there was a debate if this difference is sufficient to justify giving this treatment, given the risk, and also eventually given the cost. And so the INES considered that the difference at 18 months was not sufficient to justify giving this treatment. Now, a lot of clinicians disagree with that interpretation because you have to factor that these are patients in the very mild stages of the disease. And 0.5 point on that scale, we call the CDR, means that one of the domains where they were independent has shifted to beginning of dependence.
Mm-hmm.
And so it's 0.5, so it looks small on a scale, but it is factoring the nature of the scale of difference that is meaningful to patients.
Mm-hmm.
But the Quebec INES had a different interpretation, which is debatable at 18 months. However, what happened is that patients in these studies kept being treated in what we call the long-term extension phase. So maybe for people who are less familiar with studies, when you do a research on a medication, usually you have half people on the placebo, so no medication, half people on the drug, and then you compare them. This has a preset duration, so a year and a half in this case. But then after that, if people want, they can all continue taking the medication. So people in the placebo go on the medication, people who are on the medication continue taking it, and then we can continue following them over time. And so we now have data over 4 years of patients who started a trial and continued for 4 years. Then obviously at 4 years, you cannot compare these people to the placebo group because it doesn't exist anymore. So the next best thing is to compare them to historical research cohorts. So patients who were followed very closely in research for years without treatment. So that gives us what we call the natural history of the disease. And in Alzheimer's, we're fortunate because we have a study called ADNI, which has done that in a very professional way. So now what we can do is compare patients who are in the lecanemab study for 4 years to ADNI patients who are identical in terms of type of patient. And at 4 years, we see that the difference is getting bigger and bigger. So because the drug slows down the progression, yes, after 18 months, the difference is maybe a bit on the border of what we would consider significant, but the difference gets bigger and bigger. And then at 4 years, it is a pretty big difference. Mm-hmm. We're talking now of differences of over a point on the CDR, which means that there's really preservation of autonomy. The other way to look at it is that you reduce your chances of progressing to the moderate stage. With the moderate dementia stage is really when you have significant loss of autonomy. You reduce your chances of progressing to that stage by more than 50%. So these are numbers that usually speak to patients.
Mm-hmm. It almost sounds like, when you talk about a disease like cancer and people are willing to try different new trials or different medication to just buy some hope, buy some time. And that's what this really sounds like as well. Do you think Quebec will change their decision at some point, and what would it take?
So they will not change their position in the short or medium term. Because they have made their interpretation, and there's some arguments. It is true that when you do a trial, usually the study you look at is the registered phase 3, and if they chose to do it for 18 months, that's the game. Now, treating Alzheimer's disease is complicated. It's a long-term, slowly progressive disease. So yes, the optimal study would be to do a research trial for 4 years with a placebo group, but that would be unethical. So we have to factor what's feasible to do or not. There were some other domains, like multiple sclerosis, where similar things happen. Multiple sclerosis used to be a disease where there was a lot of fatality about it. And then at some point, biological agents started dramatically changing the prognostic. But at the beginning, there was the same kind of debate. Is it enough? Does it justify the cost? It was not covered. And over time, a lot of these drugs became publicly covered. So it is possible that this will evolve. Now, we're not in a unique situation. A lot of European countries have taken the same decision that they would not be paying for these medications. So it's not Quebec being unique on its own island.
Mhm.
But we'll see how it evolves. Also, with experience, I think this will reassure agencies that this can be done safely, because there were a lot of concerns about the adverse events. But with putting strategies in place to not give the medication to people at higher risk of side effects with close MRI monitoring, will actually reducing the risk to something that's quite manageable. And that's what the experience in other countries, like in the US, where the drugs exist for 2 years, clinicians who report on real life cohort actually found that the burden of adverse events was quite manageable. So I think the ongoing experience will become reassuring over time. The hope currently in Quebec is that private insurers will cover the medication. Now, this applies mostly to younger onset dementia, which we see a fair amount.
Which means under the age of 65.
Yeah, young onset 65. And then in that age group, sometimes we have patients who still have connections with employers, private drug regimen through them or their partner. There's no decision from the private insurers currently, but there is hope that at least some of them will agree to pay for that treatment.
So let's talk about like some of the benefits of this new drug. Like, why should people consider going through the treatment despite all of the different steps that need to be done?
So the main benefit is the slowing down of the progression of the various symptoms from Alzheimer's disease and of the loss of autonomy. So that's the number we've repeated a few times, the 30% reduction in speed of progression. So you're still progressing, but you're progressing not as fast. And over time, it makes a difference into how long you can stay independent. That's the global measure. From my perspective, what's interesting when you look at the research trial is that the beneficial effect, yes, is on disease progression, but also other important domains like measures of quality of life. So we see that patients under drug maintain a better quality of life longer. And the other important one is we also saw the benefit on a scale that measures caretaker burden, which we know is a huge factor in Alzheimer's disease. So it's very reassuring for us as clinicians to see that these are not just benefits on a standard scale of symptom, but in actual life and what matters to people, quality of life, caretaker burden, that it also makes a difference. And that is also important because when we're describing how complex the treatment is, we do know that that will also be an additional burden on loved ones because they will probably have to be involved in some ways in setting up appointments, reminders for appointments. So for us, that was very positive to see that all the types of measures are moving positively in the same direction.
And what about the risk factors? Because there have been reports about severe brain bleeding, even stroke. So what should people be concerned about?
So these are called ARIAs, amyloid-related imaging abnormality. So when the drug enters the brain, it has to go through the blood vessels, go in the brain, destroy the amyloid plaques, facilitating the removal. This process triggers inflammation which can lead to small areas of edema in the brain. So edema is a swelling, or very small bleeds, what we call microbleeds. Now, these are two phenomena we can see with Alzheimer's disease without those medications. So these are not new phenomenon, but they are obviously much more frequent with people who receive the medication. And so this is why we do all these brain scans, because we want to see them before they get too big so that we can pause the treatment or stop the treatment. So in terms of numbers, it gets a little bit complicated, but we'll try to simplify it. About a fifth of patient, 25% of patient will get at some point a reaction like this on the MRI. So this sounds like a big number, but in over 90% of them, they would never have known it. So we will see it on the MRI, but they will have no symptoms of it. Or they will have very mild symptoms that will quickly resolve. So this is why we have the MRI protocol in place. So we capture that and we can intervene. The number I would say from my perspective that is the most important for patients considering this is that once we select the right people, taking out the ones who are at higher risk, we're down to about 1 to 2%, so let's say 1.5% risk of what we call moderate or severe adverse event. So a moderate or severe adverse event would be a symptoms from the drug that is sufficient to cause at least transient dysfunction. Severe might bring you in the hospital for an emergency visits. So I would say that's the important number. Now, of that, again, the majority will have symptoms that are transient or not extremely incapacitating. But yes, because it's brain swelling and bleeding, this could lead to more severe symptoms like seizures or equivalent of strokes.
Okay. So one final question, which I know many people probably have, is so how would they go about finding out about these infusion clinics and like where do they begin? Do they speak to their family doctor? Like how do they find out about this opportunity?
Yeah, so if someone has symptoms that they're concerned about, so the typical patient for lecanemab would be someone that has noticed for a year, not more than 2 years, some progressive decline in short-term memory, slight word searching, maybe a bit of more difficulty with directions, but remains independent. And so the family around them have noticed that there is a decline, but it's still fairly mild. What I would advise people to do is to, if they have one, consult with their family physician and bring up the concern that could this be mild cognitive impairment due to Alzheimer's, and we would like to know rapidly because of these new treatments. And then they would have to get a referral to the specialty clinic that is in the vicinity of where they live. There's a clinic in Quebec City, Sherbrooke, on the South Shore. There are several in Montreal. There's one in Gatineau. Others I'm probably forgetting, but there are a number of clinics that are able to deliver this treatment. And in our specialty clinics, we're also making an effort to accelerate our processes for that type of referral. We cannot, keep the passive habit of thinking it's okay to see people in 9 months because we have a wait list. Because currently, it's not a matter of weeks, but if you wait too long, you will get people who will pass the threshold of eligibility.
Well, thank you so much for taking the time to be with us today and sharing your expertise in this field. I feel I've learned a lot in the past hour, things that I didn't know. So this has been really, really incredible. Thank you so much for taking the time.
My pleasure.
This webcast is an initiative of the McGill University Dementia Education Program, which is funded by private donations. If you would like to make a donation to our program or for more information, please visit our website at mcgill.ca/dementia, where you can also sign up for our newsletter. Thank you very much for watching.